Okay, great. Well, maybe we can get a message in the chat or in the Q&A just to make sure that everybody can see the um, webinar correctly. My name is Amir Moharib. I am so pleased to introduce you all to our combined global health grand rounds between Massachusetts General Hospital and Brigham and Women's Hospital. And I am particularly excited today because we are going to be hosting Dr. Ruma Rajbhandari and Dr. Mohammad Kashim Shah from the Nick Simons Institute in Kathmandu, Nepal. Um, I'll give a brief introduction to our speakers today. They will present, and then we will hopefully have some time at the very end for questions and answers. So if anyone has questions as the webinar proceeds, please use the Q&A function, and we will be getting to the questions at the very end. So to get started, Dr. Ruma Rajbhandari is a gastroenterologist and hepatologist here at Mass General Brigham, and she's an assistant professor at Harvard Medical School. Her expertise spans clinical gastroenterology, hepatology, and the care of patients with complex GI and liver diseases. And globally, she has dedicated her career to health system strengthening, quality improvement, and implementation sciences in a variety of settings. For nearly 2 decades, she has worked with the Nick Simons Institute in Nepal, where she currently serves as the deputy country director, focusing on improving district hospitals, expanding surgical access, and strengthening government health systems. Through the Nick Simons Institute, Dr. Rajbhandari has played a pivotal role in advancing quality improvement initiatives and establishing and expanding their research and monitoring and evaluation units, supporting general surgical care. Her efforts have been instrumental in advocating for policy action and building capacity in South Asia, and she continues to contribute to global health through much of her clinical and research work. And joining Dr. Rajbhandari is Dr. Mohammad Kashim Shah. I will say I'm very pleased to welcome Dr. Shah back. We'll say, even remotely, I was really honored to meet him a few years ago when he was visiting us in Boston. Dr. Shah is a respected Nepali physician serving as the senior program manager at the Nick Simons Institute. With more than 20 years of experience, he's dedicated his career to improving healthcare access and quality for the most remote and rural settings in Nepal. He began his journey delivering clinical care in rural and conflict-affected areas of Nepal. He's become a leader in enhancing surgical services and improving workforce retention. Dr. Shah leads the nationwide minimum standard service standards initiative, which has been implemented in more than 130 government hospitals in Nepal. And he's also a contributor to the Zero TB in Kids initiative, along with Johns Hopkins Medicine. So, in recognition of his impactful work, Dr. Shah received the prestigious Samaj Sewa Ratna Award from the President of Nepal and was nominated for the 25th Harris Wilford Global Citizenship Award, which honors individuals who exemplify a lifelong commitment to public service and global health equity. Uh, his journey reflects a powerful blend of clinical service, leadership, and policy influence, all deeply rooted in his commitment to improving lives throughout Nepal's rural heartlands. We are so, so lucky to welcome both of our speakers here today. And Dr. Rajbhandari, I'll turn it over to you first.
Thank you so much, Amir, for that very generous introduction. I'll dive right into our presentation. I'm very excited to share the work of the Nick Simons Institute in Nepal with the MGH and Brigham community. These are our disclosures. I will start off with a short introduction to Nepal for those not familiar with the country, and also to a short introduction to the founding of the Nick Simons Institute. Dr. Kashim will then lead the way in terms of describing our main pillars: the training program, the curative service support program, the hospital strengthening program, including the minimum service standards. And then I will come back in to describe our monitoring, evaluation, advocacy, and research, as well as impacts over the last 20 years. So for those not familiar, Nepal is a very small but beautiful country sandwiched between two giants, China to the north and India to the south. Just a few demographic statistics there, so you have a sense of what the health situation is like. Maternal mortality rate is about 151 per 100,000 live births, down significantly from the late 90s when it was in the 500s. Neonatal and infant mortality continue to be issues in the low 20s per 1,000 live births. There are still huge discrepancies between males and females in terms of socioeconomic status, as you can see by the literacy there, literacy rate in males being 84%, females 69%. GDP per capita is about $1,300. And recently, the Nepalese government has undergone some transformation. In 2015, we became a federal democratic system. And essentially, we went from a very centralized government to a federal government with 7 provinces, which includes 77 districts and over 700 municipalities. I'm going to share a short video with you. Unfortunately, we could not get sound to work, but I think the video is also powerful, just to give you an idea of the context in which we do our work. So let me stop this share and try to share this video. And I apologize for the lack of sound, but hopefully this will give you a sense. Okay, so hopefully everyone was able to see the video and get a sense of the type of geography that we are working in within Nepal. When we first started our work with the Nick Simons Institute in 2006 in Nepal, there were major gaps between urban and rural healthcare. The gaps still exist, although they are slowly closing, but there are still huge discrepancies. In 2006, when we started our work, rural under 5 mortality was double that of urban under 5 mortality. And doctor density dropped 30-fold between Kathmandu and rural areas. Similarly, skilled birth attendants dropped 4-fold. And this was the reality in 2008 in terms of access to life-saving cesarean section. So comprehensive emergency obstetric care capacity. You can see that only the districts outlined in blue are the ones that actually had the ability to do a C-section. So only 13 out of 67 district hospitals at the time. So less than 20% could offer a C-section. It was at this time that I visited one of our districts, the Bajhang district, which was one of the remotest and most underdeveloped districts at the time. It was also one of the first hospitals that we supported. And you can see, the level of resources at the time at the hospital. There's the inpatient ward with barely a few patients. The operating room essentially was a string of light bulbs serving as a source of light, the storeroom in complete disarray, and the delivery bed you can see with stirrups, which basically was not functioning. And if you looked at the time at what was happening at hospitals like Bachan, the population was almost 200,000, 182,000 at the time, and one would have expected 8,000 deliveries a year at a hospital like that, with at least 400 C-sections. But you can see from those statistics from 2005, 2006, when we visited, the actual number of deliveries that occurred at the hospital was 86, and there were no C-sections occurring at all. We also, as we were starting our work at NSI, we wanted to understand, what the issues were in terms of these rural and remote hospitals. And one of the biggest things was actually health worker absenteeism, particularly among higher level staff like doctors and staff nurses. We actually did spot checks of some of these hospitals to see, if employees were present for the entire 12 months of the year or not. And what we found, which was that essentially doctors were present, only for about 50% only 50% were really present for 12 months of the year. So there was a lot of absenteeism. Usually what would happen is the doctor would come for about 2 or 3 weeks and then leave to go to various trainings or to go back to the city. They were not present for the full year. And similarly, staff nurses were a little bit better, but still a lot of absenteeism in that cadre as well. And the cadre that actually were working and were present at these hospitals were the lower level health workers, like health assistants and auxiliary health workers. And the reason they were there is because they were from the local areas. They had homes there, so they tended to stay and work in those hospitals. So it was, in that backdrop, in that setting of essentially, extremely, under-resourced settings with absentee health workers and really, underutilized health facilities that the Nick Simons Institute was born. And it was an organization with a mission to innovate solutions in rural healthcare through training and hospital support, and to advocate for their scale up within the government of Nepal. And our vision was really that people in rural Nepal should receive quality healthcare services within their own communities. The organization was set up through a very generous donation from the Simons family. Nick Simons was a young gentleman in his early 20s who had spent a year after college working in Nepal, had fallen in love with the country and decided that he wanted to become a doctor. Unfortunately, on his way back to the US, he had a tragic accident and passed. And his parents, Jim and Marilyn, wanted to do something in his name in healthcare in Nepal. And thus the Nick Simons Institute was established. I think the way in which the Simons, carried out their philanthropy is another lesson in philanthropy that perhaps others can learn from as well. What they did was essentially bring together healthcare leaders in Nepal and, around a table, and they essentially put a blank sheet of paper on the table and said, we want to do something in healthcare in Nepal. You tell us what to do. And so that's how the Institute was born. This is our current office space in Kathmandu and our current office staff. We have about 40 staff based at our headquarters in Kathmandu, but we also support almost 300 healthcare workers, including doctors, nurses, anesthesia assistants, biomedical equipment technicians throughout the country. And if I think about, what makes the Nick Simons Institute unique in terms of the work we've carried out in Nepal, these are some of the unique characteristics. We focus on curative services, which is actually a rarity. There's a lot of funding in low and lower middle income countries for public health services or for disease-specific services, for HIV, TB, malaria. But there is there are very few groups that actually focus on curative services at the hospital level. The other unique feature of our work in Nepal is that we work in close partnership with the Ministry of Health of Nepal. And we don't build our own hospitals. Everything that we do is with the government hospitals. One of my main mentors in Nepal, Dr. Mark Zimmerman, who was the first executive director of the Nick Simons Institute, said that working with the government is like moving an elephant. It's very difficult to do, but when you do it, there's an immense impact. We also focus on relatively small inputs that would have big impact. So we don't want to, take over a hospital and create this excellent island of excellence, that would be in one area only. We really wanted to provide small inputs at a national level that would create bigger impact. And then obviously, our kind of donor situation and our funding situation is very unique in that the Simons really set up an endowment and a perpetual fund so that we could focus on longer term projects. We did not have to think about, short 3 or 4 year projects, but we could think in the long term in terms of 10 or 20 years. I think our model is also unique in that we think about the health system as a whole. It's not a vertical model of just one disease. And I think another unique feature is that we try to focus on research and advocacy as well, so that we can learn from our programs and advocate with the government to scale them up at a national level. So this is a map of the sites in which we work. And essentially, you can see that we are a national program. The heart of our program is the Curative Service Support Program. And through that program, we support intensively 40 hospitals in all 7 provinces. We also have the hospital support or hospital strengthening program that is on a nationwide level, and that's more of a quality assurance program through the minimum service standards. We also support 21 government training sites and 6 provincial biomedical units throughout the country. Now I'm going to pass over the baton to Dr. Kashim, who will talk about the various programs at NSI.
Okay, thank you, Dr. Ruma, and thank you for the organizing committee for this platform where we can share our work in Nepal. Nick Simons Institute has strategically focused on 4 areas to enhance the healthcare system in Nepal. The one is training, another is curative service support program, and hospital strengthening program, and monitoring, evaluation, advocacy, and learning. These are the 4 areas where we are working since the beginning. Next slide. And now I'm going to tell about in brief about the training program, and this is the crucial piece of NSI program. And we started our program in 2006 from training for the healthcare workers who are working in the remote area. And we support all aspects of the training of government workers and specific cadres, especially suitable for the workers who are working in the rural and remote Nepalese hospitals and health facilities. And in training, we support, for example, to set up the training site. We also support to develop the curriculum, and if they need revision, we also have for that. And in addition of that, we also have support for the institutional support, and we conduct the various training for paramedics and nurses. Next slide. And among the training, we produce two unique healthcare workers. One is anesthesia assistant and another is biomedical equipment technicians. There were no anesthesiologists serving in government hospital when we started our program in 2006. At that time, we wanted to do some emergency surgical intervention in the hospitals, especially in the government district hospitals, and there was shortage of surgeons, shortage of anesthesiologists. So, in order to make C-section possible, we had to train cadres of workers who would be able to carry out spinal anesthesia and deploy them to rural hospitals. And we started 1 year course. We call them anesthesia assistant. And currently, this program was running in 7 different training sites. And another important and unique healthcare cadre is biomedical equipment technician. And this was also another cadre that was not exist when we started our program in 2006. And everybody knows about the problem of lack of maintenance of medical equipments in hospitals. Even WHO, World Health Organization, estimated that more than 50% of equipments in the hospitals, especially in lower middle income countries, are not functional, not used correctly, and they are perpetually not maintained. Every hospital had a room of full of non-functional equipments that you can see in this picture, in this slide also. But nothing was being done about this. And NSA was started to think how can we address these issues, and in collaboration with National Health Training Center, we developed the BMET course, which has gone from certificate level to diploma course. Now this is 18-month course, and we produce the biomedical equipment technician in Kathmandu. So the Nepal government has no post for anesthesia assistant, biomedical equipment technician, and now these posts are formally created in government district hospital, and I think this is the very important and great achievement for all of us. Next slide. Regarding training, besides this diploma in biomedical equipment engineering course and anesthesia assistant course, we also provide training which is suitable for maternity services and emergency health workers who are working in the emergency department. For example, skilled birth attendants and advanced SBA course for the doctors and nurses. And we also provide mid-level practicum for the paramedics. And we don't have operation trained nurse who are working in the operation theater. So we develop short duration, about 42 days operation theater technique management who are working with us in operation theaters. Next slide. So annually, we can provide training about more than 800 health workers, and so far we provided training for more than 8,000 health workers, and we are supporting training through 21 training sites, as Dr. Ruma mentions in her presentation, and we also have support in 6 provincial biomedical unit in all 6 different provinces, and we set up a small biomedical unit in NSA supported hospitals, and currently we have 35 biomedical unit in NSA supported hospitals. And now I'm going to brief you about our another program we call Curative Service Support Program, and this is the another flagship program of NSI, which is designed to empower our rural hospital to deliver essential emergency care. And this program was begun in 2006. Initially, it was started in 3 rural hospitals, small hospitals, and over the years, for last 17 years, 18 years, the program was gradually expanded across the country and reaching a total of 61 hospitals. And currently, we have 40 hospitals under this program, and they are spreading throughout the country. Next slide. The core component of CSSP program is the human resources. where we provide the key human resources to ensure skilled professionals are available in the hospitals, and we also provide essential medical equipment to deliver life-saving services, especially for the operation theater and delivery room. And we also provided support for the comfortable living arrangement to health workers working in remote areas. In addition, communication support is provided to help staff stay connected with their families, and we want to boost their morale and retention in the remote setting. The program consists of several key areas of the support. The foremost is the team of human resources that we recruit and deploy, with the centerpiece of being the MDGP doctor. And our MDGP doctor is like family practice doctor in other countries, and they are jack of all trades who can carry out surgeries like C-section, appendectomy, and they can also repair hernia, and they can take care of adults and children. And in our experience, we find that this type of doctors is ideal for the rural setup, especially in the district hospitals where we were trying to make this hospital functional. We coined the term journalist Shah team to refer to this team as opposed to the specialist surgical workforce that the Lancet indicator refer to in terms of surgeon, anesthesiologist, and obstetrician, particularly when referring to Shah density. And MDGP program, this program was started in 1982, and this was the first postgraduate program in Nepal. Next slide. And to strengthening this initiative, in 2006, we began MDGP scholarship program, and we provided over 70 MDGP by 2015. Recognizing the importance of this broad-based rural clinician, the government of Nepal took a major step in 2015 by initiating its own scholarship program, supporting around 50 MDGP trainees each year. As a result of this combined effort, Nepal has produced over about 500 MDGP doctors uh, between 1984 to 2020. And these are the main healthcare providers and service provider in the remote hospitals. Beside human resources, another key piece of support was essential equipment, and particularly we provide the equipment which is useful for operation theaters, delivery room, and sometimes we may need to provide support to the laboratory room. So we are providing this type of support since the beginning as a key component of our program. And we are also aware uh, about the living condition of the health workers working in the remote areas. That's why we are providing support, living support for the staffs. In some hospital, we build the staff quarters, and currently we are supporting with rented house. Or sometimes we may need to furnish the staff quarters. We may need to renovate the buildings. Like this way, we are supporting our health workers in living for their living support. And this slide shows the success of this program. And through this program, more than 8.5 million patients received care in outpatient department, while approximately 1.8 million were treated in emergency unit, and more than 28,000 cesarean operation was done through this team of the health workers in the remote hospitals. About 300,000 mothers deliver. So this figure reflects the program's significant contribution to expanding access to vital healthcare services across the country. You can see from this graph that the average number of outpatient visits in NSI supported hospital has increased from about 8,000 to 31,000 per hospital per year. Likewise, Next slide. Similarly, emergency room visit also have increased significantly. When we started our program at that time, the number was 1,500 in average per year per hospitals, and now the number is about 6,000. Inpatient admission have also increased, although not to the same extent. When we started our program in 2006, very few number of hospitals were able to provide C-section. Now, in average, about 100 C-section was performed in NSA-supported hospital per year. Next slide. Now, I'm going to brief about the another component of our program. This is called Hospital Strengthening Program, and this is our third pillar of program component. Next slide. District hospital in Nepal were accessed through the minimum service standard tool in terms of governance and management, and we also access the clinical service management and support service management. To address these challenges under the leadership of Ministry of Health and Population, we developed this program and now implemented in most of the hospital, from primary hospital to the specialized hospital. Next slide. The tool consists of very detailed standard like this, and there are the number of tools are depends on the level of the hospitals. In average, there are more than 1,000 hospitals in secondary standard in secondary level hospitals, and we try to assess the hospital readiness based on these indicators. Next slide. I already mentioned that the MSS tool was piloted in 2014 with the support of Nixam Institute, and since then the tool has been revised, and now this program was implemented in almost all hospitals, government hospitals, and currently this program was active in 133 hospitals. Okay, next slide. In summary, the initiative led by NSI have had a significant impact on strengthening rural healthcare service in Nepal. For example, key health workforce cadre like MDGP doctors, anesthesia assistants, and biomedical equipment technicians have been developed, and these are institutionalized within the government system. Similarly, specialized training, for example, mid-level practicum, anesthesia assistant, biomedical technician, and operation theater and technical management have also been successfully integrated into the government system. Additionally, minimum service standard program has been developed and now totally scaled up in the government and implemented throughout the country. In total, we can say that the trust of the government hospitals, they are gaining the trust from the community and the different stakeholders in the country. Thank you.
I will now talk about sort of our monitoring, evaluation, advocacy, and learning, which is the fourth pillar of our programs. And we try to document learnings from our programs, the impacts of our programs, and the learnings from them in academic journals, in both Nepali as well as international journals. And we also try to create policy briefs, which are more likely to be, read by government officials than academic papers. So we try to, advocate and spread knowledge in these ways. We also try to present whenever possible at both local and international conferences. And finally, a big piece of our advocacy is actually an annual Rural Healthcare Workers Conference that we hold in Kathmandu. And this is really catered for the mid-level cadres that we support at our district hospitals. So we bring in health assistants, we bring in nurse midwives from, almost every single district working in very remote and rural areas. A lot of times, these are not people that have the opportunity to come to a fancy hotel in Kathmandu and, come for continuing medical education, because those things are usually reserved for doctors. So this is a nice opportunity to bring those workers in. And we actually give out an award every year for the healthcare worker who has really gone above and beyond their call of duty, and present an award every year at that conference. I will try to go through a few of our most important studies, particularly showing the impacts of some of the cadres that Dr. Kashim talked about, particularly, the biomedical equipment technician cadre. That was a completely new cadre that did not exist, prior to the start of our work. And then also the anesthesia assistant, and then obviously the MDGP doctor as well. So we tried to look at the impact of the biomedical equipment technicians on the functionality of medical equipment in government hospitals. We actually carried out a mixed method study with a comparative design, and we assessed over 2,000 pieces of medical equipment at 22 hospitals with and without the BMET cadre to observe how functional these pieces of equipment were. And we also did some qualitative work interviewing both BMETs as well as other hospital staff and hospital superintendents. One healthcare worker stated, in the operating theater, when there is a BMET, we feel so confident. We can tell him if any equipment is malfunctioning. He fixes the cautery machine anytime during the procedure if there's a problem. So there's a difference when we have him. All are confident. And in terms of the quantitative results from that study, you can see in orange are those hospitals without BMETs, and in blue are the hospitals with BMETs. And you can see that the percentage of non-functional equipment in various departments, from the lab to the operating room, are definitely much, much lower in hospitals with the BMET, and these were statistically significant. And, just to go back to 2006, this cadre, the BMET, or there's also a separate cadre called the BMEAT, which is kind of the assistant technician. And so these cadres, they did not exist back in 2006. And now, the 2023 reality, you can see that in almost every single district, there is at least an assistant technician. And in many districts, there is a full BMET technician as well. And this is only continuing to expand because the government has actually created a post for BMETs at district hospitals. We also have the provincial biomedical units that support the district BMETs within the province. I'm going to spend a little bit of time talking about the GP and this entire team of people that we support, that we call the generalist team. We essentially tried to study the effect of this team on surgical coverage and access in remote Nepal. And we mapped surgical care and the enabling environments for surgery in 39 hospitals in 25 very remote districts in the country. And we compared it to the Lancet surgical indicators. And as Dr. Kashim mentioned, the Lancet indicators recommend looking at specialist surgical density. By specialists, they refer to surgeons, anesthesiologists, and obstetricians. And in our setup in rural Nepal, we felt that this wasn't completely relevant because we didn't have anesthesiologists or obstetricians or surgeons working in many of these remote districts, particularly back in 2006 when we first started our work. So we really wanted to look at the GSAO density, or the generalist SAO density. And we found that these GSAO teams, led by these GP doctors or family physicians, are providing essential surgery, with cesarean section being the most common. And the GSAO density was 8 times higher in these very remote districts. And they were conducting more operations than cesarean sections alone. This was data from 2016, and we're continuing to update that currently. But the ones I'm showing you are from 2016. This is data from those 39 districts, 25 hospitals, showing the surgical rates of bellwether procedures per study district. And you can see here that the numbers of surgeries are actually still, we're still quite low in 2016, only on average about 387, not quite 400 operations per 100,000. The red line up above here is actually the Lancet target indicators, which are 5,000 operations per 100,000 population. So those districts were, were carrying out surgeries, but in, very low numbers. And most common operation was the cesarean section, but other operations included the closed treatment of fracture, DNCs, incision, and drainage as well. We also looked at in that study whether the CS met, whether and how the CS met need compared to the generalist SAO density and the specialist SAO density. The blue lines represent the met need for CS in the district, and the orange lines are the generalist SAO density, and the green are the specialist SAO density. So you can see that there are very few specialists. There were only a handful of districts that actually had specialist doctors. This is a bit of an outlier in Jumla here, where there is an academic center, so there were specialists there, but in most of the districts, specialists were very hard to come by. However, if you look at the orange bars, the generalists, the GPs, the anesthesia assistants were there in most of these districts carrying out surgeries like cesarean sections. And in fact, the GSAO density was the biggest predictor of CS met need in these districts. So our main takeaways, from that paper were that this family physician or GP-led functional teams are providing a pathway for effective surgical coverage in remote and rural areas of Nepal. And finally, one last study to talk about. Dr. Kashim mentioned this minimum service standards program that we have. It's sort of a quality assurance tool for different levels of hospitals. And we, took it from a pilot project in 2014 to a nationwide project that now is completely owned by the government and implemented by the government. We still support a few of the districts in carrying it out, but largely the government has taken ownership of this project. This was a recent study from this year that we published some of the findings from our baseline assessments using the minimum service standards back in 2014 and compared them to our most recent assessment of the hospitals in 2023 and 24. And as you can see, there have been significant improvements in a number of indicators where, the baseline was around 52% for many of the indicators. Now that baseline has moved to an average of 83%. And some of the, basic things that have improved through this program are whether or not free medicines were stocked in the pharmacy, whether or not cesarean sections were available, whether or not there was 24-hour ER and triage, 24-hour X-ray service. So all of these things, just essentially from laying out a blueprint of what a hospital should be doing and what a hospital should have, and providing a small amount of funding so that they could, carry out these improvements, we saw major changes. And a qualitative piece of the study also showed that there was a very positive response to it. One of the healthcare workers said the MSS program has instilled a newfound drive among hospitals to outdo each other. They are striving to excel not just for the sake of better scores, but to deliver quality healthcare services. Another medical superintendent commented, with the MSS scores, our objectives have transformed. We no longer aim to merely sustain our services, but to be recognized for providing quality healthcare and setting benchmarks for others. Our clear goal is to offer the best patient care and strive for continuous improvement. I think I'm going to speed through some of these slides now so that we can have time for questions, but just wanted to show you, some before and after. This was, the Bajang in 2007. Dr. Kashim and I actually visited the hospital again in 2024 last year. We actually supported Bajhan for about 10 to 12 years and then stopped our support. So we wanted to see what was happening to the hospital after our support had ended. And I was very pleasantly surprised to see the amount of services, the resources, and the types of care that patients were receiving. There was a patient with a patellar fracture who was being managed by an orthopedic surgeon who was, serving in the hospital. There was even a blood bank with actual stored blood, which is a very uncommon finding in remote Nepal. Many of the hospitals have walking blood banks, so that was quite a surprise. And they had several functional X-ray machines as well. And finally, this is one of my favorite slides to show you because if you remember, I mentioned that less than 20% of hospitals in Nepal could do a C-section in 2008, and this is the current reality. So almost 100% of the hospitals now have C-section capacity and are doing C-sections in the 77 districts. There's only a single district outlined in red named Manang, which only has a population of about 6,000 that has not carried out C-sections, but otherwise all of the districts are able to do it. And the ones that are shaded in green are all of the districts that NSI has supported over the years in terms of developing C-section capacity. The ones in blue are districts where the government has received other supports. So I would say, as Dr. Kashim outlined, I would say our biggest wins are, building up C-section capacity to now almost 100% of districts, having innovative programs like the MDGP, the BMET, the anesthesia assistant, and the minimum service standards program. And really, I think it speaks to the effectiveness of these programs that the government has taken them on. We could stop giving away our MDGP scholarships because the government started doing it. We didn't have to do it anymore. Similarly, the BMET and AA programs and the MSS programs are programs that have been fully, taken up by the government and our government programs. So these were, I would say, the biggest kind of wins for us. And most recently in 2023, we were also awarded the Sasakawa Health Prize by the WHO for our work with human resources for health in rural Nepal. This is our current executive director, Dr. Archana Amatya, accepting the award on behalf of the organization. Unfortunately, she couldn't join us today because she's on a flight right now, but that was a really proud moment for us. And then finally, in terms of future directions, I think that, there has been a bit of neglect, I would say, of these district or first referral hospitals in global health in general. There's been, a lot of work on disease-specific programs, vertical programs, but when it comes to broader efforts like this in terms of health system strengthening, there hasn't been as much funding. So I think there is it's about high time we paid attention to these first referral hospitals because they are very important in terms of the type of work that they do and their impacts. I also think we need to leverage global interest around non-communicable diseases and global surgery to improve facilities and hospitals like this. And certainly for NSI, now that we have solved to a certain extent the access to C-section issue, we do want to broaden out into other areas of care like non-communicable diseases and other surgeries as well, beyond bellwether operations. I also think that quality is a big piece of where we need to go, and the minimum service standards program is a first step towards it, but there's a lot more to do in terms of quality of care in these hospitals. There's also a recent phenomenon with, the federal structure in Nepal, where there is a lot of funding now at the local level, where there is a bit of a mushrooming of hospitals, and really with a focus on infrastructure without really focusing on the human resources and quality, which I think we need to tackle as well. Finally, thank you to the Nick Simons Institute staff, the foundation, and of course the Ministry of Health, without which none of this work would have been possible. I do have the ending if you want to see, what happened to that woman. But I also want to save time for questions. So there is a link if you want to see the rest of that, documentary about one of our hospitals.
I think we may want to see it.
No, no problem. So let me stop this share and share that video. Let's see.
Thank you both so much for this really incredible presentation. Uh, so we have a number of questions coming in, and one of the questions, so I'll go through a couple of them quickly. We have 3 or 4 minutes left, but one question I have for you is related to your partnership with government. It seems like that has been both very deliberate and also a really important catalyst for scale. Um, and you talked about moving an elephant out of the road, etc. Like it's difficult to do, but it's important for sustained impact. Can you speak a little bit about that partnership? And we had a question that came in early from somebody who, in the audience who sounds very, very knowledgeable of the system, asking about also how in charges at facility level could be more included in planning, and whether local facilities can be part of interventions that are being designed, and how Nick Simons Institute could be influential in that, which I think is related to the questions of government partnership and how you think through the initiatives that you choose to focus on and then how they're scaled up.
Sure. So I think, in terms of the government partnership, that was certainly very, very deliberate. Our first executive director was actually in his prior life was a mission doctor. So he was serving in a mission hospital in Nepal. And I think, what he realized from that experience was that you could create, these amazing hospitals, right? These amazing entities if you ran the whole thing, if you put in all the resources, and you have, these amazing facilities. But they are, not government facilities. They are, kind of standalone islands of excellence. But when you think about the nation as a whole, there's no way to do that across the nation. You really, I think, to have any sort of, kind of impact at a national level, you really have to work with the government and with government facilities. There's no way around that. And I think in terms of sustainability too, that is, a huge factor. And one of the first kind of partnerships that we had with government was actually with the National Health Training Center. So that's the body within the Ministry of Health, which is responsible for training health workers for the entire country. And so that was our biggest partnership in the beginning, because we really needed, to train these health workers first. We didn't have anesthesia assistants. We didn't have biomedical equipment technicians, didn't have GP doctors. So that was the start of the partnership. And then eventually, as we have expanded, in terms of our curative service support program, we've expanded those partnerships to not just be with training, but we work closely with the curative service division of the Ministry of Health. Everything that we do is in lockstep partnership with them. We don't do anything without consultation with the government.
Thanks. I'm going to squeeze in one more question, and maybe Dr. Shah, you'd like to take this one, or however, which is about incentives for MDs or nurses or midwives or other healthcare workers to stay in rural areas, or training programs that are really focused on that. How is that organized, or are there policies related to that to try to encourage physicians, healthcare workers in rural places?
Okay. Principally, we are working only with the government, as Dr. Ruma mentioned, and government is the only stakeholders. So to implement any program, either in training or curative support, hospital support program, or minimum service standard, there is a working committee in the government level, led by the secretary in the Ministry of Health and Population. And in this type of working committee, like supreme decision-making committee that help us to guide our pathway to work where we need to go. So in terms of training, in terms of hospital support or hospital assessment program, this working committee is the leading body in the government systems. And we are only supporting the hospitals and government system, and we are not going to run the hospitals. So this is our principle. That's why we have very close and a very good relationship with the government.
Great, thank you. Unfortunately, we're out of time, but I know there's lots of compliments for your presentation in the chat, and you've left us all wanting to know more, but we're really appreciative. Thank you so much. Thanks everybody for joining us today. We really appreciate you being part of the global health community. Thanks, Doctors Rajbhandari and Kashim Shah.
Okay.
Thank you so much.
Thank you so much.